technology is available to provide positive transformations, yeah, but also the humans are the people that are going to be making those decisions about how that technology is deployed, whether it's safe and effective for use, how acceptable it is to patients, how acceptable it is to clinicians. And that's in context of the UK strategic imperative to boost productivity and part of economic growth. Fundamentally, I don't believe that it will happen without the support of clinicians and patients, the human dimension.
If AI is going to change healthcare, it's got to begin with listening, not just to data, but to people. In this episode, I'm joined by Rhonda Siddall. She's a medical writer, a journalist, and she's a healthcare communications expert. She's worked across the NHS and national public health campaigns. But what makes Rhonda so compelling isn't just her experience, it's how deeply human her view of medicine is. This conversation isn't a tech hype conversation about AI in healthcare. It's about what AI in healthcare really looks like when you strip away the headlines and look at what actually matters. Trust, compassion, safety, and reform. In this video, we explore whether the NHS is even ready for AI, how this technology could predict and prevent illnesses, the dangers of bias baked into existing healthcare data, and the deeper question of whether we want care without a human face. And then we'll close, as always, with the final question, whether Rhonda believes AI will take us to a utopia or dystopia. This is BASELINE051. Let's get into it.
Baseline.
The baseline is designed to create an emotional response.
I've seen things you won't believe.
More human than human. Make you question everything.
In the battlefield, you have soldiers that are well trained, and there is planning and there is anticipation. But actually, in the battlefield, the chaos, there can be unexpected turn of events, etc. And the brain switches between system 1, system 2 type thinking, which is based on the ability to use experience to deal with those kind of scenarios. Kind of two different ways of thinking fast and thinking slow, and thinking in a way where you are very consciously using attention, or thinking in a way where you're almost kind of working on autopilot, but that autopilot is driven by experience. Don't ask me to actually kind of drill that down into really specific neuroscience. But the only reason I wanted to go into that point is I wanted a bit later, because I'd like to look at the question of the NHS in crisis first. But I'd like to connect this point of experience as being so important in terms of AI deployment in the NHS, the experience of human beings, not only the clinician's experience after many years of training and then working as clinicians, but also the living experience of patients.
We begin where the stakes are highest, the NHS. Rhonda doesn't just talk about numbers. She talks about the experience, burned out clinicians, patients waiting months, and a system that's stretched to breaking point. As of last month, there are 7.2 million people on the UK NHS waiting lists. But she also reminds us what's still well and truly alive in the NHS: compassion. This section is about what we risk losing in the rush towards automation, and whether AI can help save the NHS without losing its soul.
So to go to your point, Is the NHS in crisis? Yes. There have been only a year ago, Lord Darcy brought out a report. He was asked by the government to take a look at where we are at, and his conclusion is that the NHS is in a critical condition. It is in crisis. And the main reasons that he assigned to explaining that were years of austerity, lack of capital investment, and the pandemic. And I think the pandemic is what accelerated what was already going wrong within the NHS. And ballooning waiting lists, patients can't get GP appointments, etc. Though I would say my recent experience of going to 2 hospitals, one in London, one in Manchester. I took my elderly relative for an operation, and I went to an advanced dementia ward. I visited it in Manchester. And in both settings, what really struck me was the compassion and the care. So whilst there are so many unequivocal statistics that show the NHS has to reform or die, that compassion and care, yes, there's staff burnout, but the compassion and care is absolutely at the heart of the institution, which, can AI retain that? How can AI augment care that is given that is still based on compassion and care and experience?
Now we shift to something much more hopeful, the promise of AI in clinical diagnosis. Rhonda is about to share examples of AI that can predict serious illness days before even symptoms appear. COPD flare-ups, rheumatoid arthritis, even diagnostic enhancements that free up doctors to spend more time with patients. It's not just about efficiency, it's about changing the whole philosophy of care, from treating disease to preventing it.
What I'm seeing is there are many reports of the potential of AI in so many areas of clinical medicine. Okay, so say from in chronic obstructive pulmonary disease, using machine learning, combine that with data from digital inhalers, and there's studies that show you can predict exacerbations of COPD 5 days before they're going to happen. That is pretty exciting, because a COPD exacerbation is really serious. It can result in hospitalizations, mortality, and all sorts of other things. So, the idea that you could predict those exacerbations, which means that things can be done from a therapeutic point of view to prevent them, and also learn why that exacerbation is occurring. I think that's pretty exciting. And, if I'm taking out the AI that is exciting in terms of being able to reduce workload and increase diagnostic confidence for doctors, that's exciting, because if that frees up clinician time where more direct care, if you like, can be delivered, more people get an earlier diagnosis, more people get the right treatment, more people aren't on waiting lists, that's really exciting. And, something like rheumatoid arthritis, for example, that is a disease, it's an autoimmune disease where there is a window of opportunity. If you intervene early in that window of opportunity, you can switch off the disease. The disease has the potential to be switched off, which is massive, because it's a chronic disease, and there are great treatments now that mean that people don't have the outcomes that they used to have. But now AI, there's work that shows that flares can be predicted. Again, that means intervening earlier, getting the right treatment. So, just those 2 examples, and there are many others across many illnesses. I think those 2 examples show how there can be a real kind of seismic shift in the way that AI can support the fact that maybe doctors aren't always dealing with the outcome of the worst of an illness, but actually, predicting the worst, being able to manage that, and ultimately maybe be able to prevent it.
In the next section, we ask a really important question. Who gets to benefit from AI in healthcare? In this section, we dig into the hidden biases in healthcare data, especially the gender gap. It's led to misdiagnoses, mistreatments, and generations of assumptions about women's health. Rhonda explains how systemic bias creeps into data and why equity in AI starts with whose data and who we choose to include.
It's long been known that there's a gap, a gender gap in health data, and I think there are a number of reasons for it, some of which include the fact that women were sometimes excluded from clinical trials, and that much of the data was male data. And that was partly around, when you're trialing a drug, not, if a woman is of childbearing age, how might that impact on childbearing, or if a woman is pregnant, etc. So, assumptions around women's health compared to men's health, like there was an assumption, that cardiovascular disease was mainly a male disease, which is partly derived from, the kind of the male data, if you like, and that's just not true. So I think it is important to address, if data is going to be used more and more and AI more and more, it's really important to address some of these issues. How they're addressed, generating new data in which women are more represented, for example, disaggregated data, so that at least the bias is known or clearer. In the NHS we have really rich data sets because we have data from cradle to grave and the best population data in the world. And that population data will represent diversity, the diversity of this population. So perhaps if those data sets are unlocked and using the power of linkage, then that richer data could inform better the deployment of AI in healthcare than other sources of data.
What if patients trusted machines more than they trust doctors? Because it's smarter, but because it doesn't judge. We explore that tension in this next section, between shame and safety, between convenience and compassion. We talk about mental health therapy bots and the rise of humanless healthcare. This is where the conversation gets personal and philosophical. Because if AI is going to become a core part of medicine, we have to ask, is it enough to treat illness if we forget to care for the human?
Yes, it's a good thing that you're not sitting for 5 hours in A&E or sitting in a GP practice with people coughing, or you're frustrated on the telephone trying to get a GP appointment, etc. But the human element, I think, is still really, really important. The care, the compassion, and you've mentioned that there maybe are, sometimes when people don't want to open up to doctors and they don't want to talk about certain things, and perhaps that might be for someone who's struggling with their mental health, for example, and is masking that. But if that is a scenario, for example, but it was really important for someone, for a person with lived experience, a patient, to share, their symptoms, to really share what they're going through, to really share, their circumstances, all of which are important, as well as the biomedical model. Okay, can AI elicit that? Or is that more likely with a human smile, with a human face, with human eye contact, with human expression, with empathy, with the feeling that you get when someone is listening to you? And I think that's still a really, really important part of medicine, hugely important. What about principles like first do no harm, which is a fundamental principle of medicine that guides the therapeutic relationship between a doctor and a patient and clinical decision making? And that's entirely, completely enshrined in medical training, medical practice. How is that enshrined in AI?
It's complex. And there's a lot of complexity around ethical and responsible use of AI.
Yeah.
And the legality of AI, specifically AI decision making. I think this is where we come to a bit of a stumbling block as we sit here today. If you think about AI augmentation in the interpretation of data as a tool for the clinician, as a accelerant for a process, but ultimately someone somewhere has to be responsible for decisions being made. And I wonder how, as a social structure, do we make the leap from having a experienced, educated, trusted clinician or group of clinicians being responsible for healthcare decisions to, are we able to make a leap to algorithms and systems and AIs being responsible and accountable?
But also as a human being, the interactions we have with each other and all of the ways in which our brains, teach us without us knowing, we learn it, how to interact with others and what to learn from and how to be informed from cues, tone of voice. I don't know, Ken, is there data out there that kind of replaces all of that type of human learning? There are many drivers for people not wanting to share and suffer in silence, stigma, shame, self-denial, I'm coping, masking, all these kinds of things. And there is a huge amount of evidence to show that talking about how you're feeling and what you're thinking is a good thing, is helpful. That's why we have a whole branch of therapists called talking therapists. So I can see the benefit in context, particularly of people who would rather not share with a human. And in fact, I was at a conference earlier this year, and this is in the world of banking, actually. This is not healthcare. But I met a chap who works for a major bank, and we were having a conversation and talking about AI and tools that relate to people who've been scammed and that relate to people who've experienced fraud, okay, and have been fooled. Often feel, a bit could feel a bit shameful about that, and might not want to sort of really open up. But opening up about the experience is not perhaps also good for their mental health, but also really important to give as much information to people who can try and prevent that happening to other people. And in this conversation, this chap was talking about how, I can't remember, to be honest, if he said they had data or whether it was looking that way based on some anecdotal case studies. But he was saying that there's definitely a trend where some people would rather open up about, their story of being scammed, for example, to an AI digital coach.
We close with the big question of whether AI will take us to a utopia or a dystopia, and where it's all going specifically in healthcare. Rhonda's not dodging this question. She roots her answer in the reality of the NHS and the reality that the NHS must change. AI may be the best shot at helping make that change, but she leaves us with a challenge to make sure that transformation is human first, not system-led.
I haven't got a crystal ball, but what I believe is that it will take us to a utopia. It's not being discussed and introduced as a quick fix, as a purely perhaps money-saving initiative. The reality is that the NHS really, really does need to have a radical change and reform. 20 years ago, a front page cover of the British Journal of Healthcare Management, Alan Maynard, well-known health economist, said, if the NHS does not change its behaviour, it will struggle to survive. Crises like the financial crisis, austerity, the pandemic have accelerated that. And we are at a point where something really radically different needs to happen. And I think AI and digital tools are that radical change.
This is a very important discussion about the application of technology in a very human environment. And I'd be fascinated to get your view in the comments below, in your experiences with the NHS and how you feel about humanless healthcare and the integration of AI into the systems that care for you and your families.
We are in a computer game.